Hello, and thank you for listening. This is Dr. Colin Dunn, the Research Fellow at the University of Southern California's Division of Upper GI and General Surgery. Today I'd like to present a follow-up study showing longer-term outcomes of regression of Barrett's esophagus after magnetic sphincter augmentation of the lower esophageal sphincter. As part of the disclosure, Dr. Lippam and Dr. Bildzukevich, the final two authors on the paper, have served as consultants for Ethicon, which makes the MSA device. As the prevalence of risk factors such as obesity and older age continue to rise in the general population, the incidence of gastroesophageal reflux disease and Barrett's esophagus is also increasing. The current prevalence is now estimated at 11 to 25%. There is an associated risk of malignancy ranging from 0.3% per year in non-dysplastic Barrett's to 7% in high-grade dysplasia. Given the high prevalence and risk of malignancy, new effective treatments for Barrett's esophagus are needed. Previous fundoplication studies have demonstrated regression rates of 25 to 35% within retrospective reviews. However, this effect is not borne out in prospective trials. This variability may be attributed to the technical difficulty associated with fundoplication, and therefore the variability in construction of an effective wrap. Magnetic sphincter augmentation may lead to better outcomes by standardizing the amount of pressure applied to the lower esophageal sphincter and eliminating some of the technical difficulty associated with this procedure. We therefore set out to examine our own outcomes with respect to Barrett's regression after magnetic sphincter augmentation. After obtaining approval from the Institutional Review Board, a retrospective review of prospectively collected data was obtained. All patients at our center undergo annual upper endoscopy with biopsy and video esophagram as part of ongoing research efforts. To be included in this study, patients needed to have intestinal metaplasia before their MSA placement, and they should not have had a former fundoplication. Cold forceps biopsies were taken every 1 centimeter within any visible area of nodularity, every 2 centimeters within a known metaplastic region, and every 2 centimeters throughout the remainder of the non-metaplastic esophagus. All patients completed the GERD Health-Related Quality of Life questionnaire preoperatively. Then patients returned for clinical follow-up at 2 weeks, 6 weeks, 3 months, and then annually. The Barrett's length was subcategorized into ultra short, short, and long based on whether they were less than 1 centimeter, 1 to 3 centimeters, or greater than 3 centimeters in length. 87 patients met criteria for inclusion in the study. 57% of the patients had long-standing GERD symptoms greater than or equal to 10 years in duration prior to their procedure. 63% of the patients were male, 25% of the patients had ultra-short Barrett's, 66% had short Barrett's, and 8% had long segment Barrett's. The overall follow-up of the study was excellent, with postoperative Demeester scores in 86.5% of patients and 85% of patients having follow-up EGD with biopsy. 68.9% of the patients had more than one postoperative biopsy. The mean follow-up time was 2.35 years, plus or minus 1.57 years, with the maximum at 5.55 years. Overall, 9.5% of patients had a partial reduction in the length of their Barrett's, i.e. from long to short, and 60.8% of patients had complete resolution of their Barrett's. Complete resolution was more likely to occur if the patients initially presented with ultra-short segment Barrett's. Here is the data in tabular format showing the patient's initial preoperative Barrett's length and their Barrett's length at last follow-up. And here is a graphical representation of that data. The y-axis represents the number of patients, the left column represents the proportion of patients within each category preoperatively, and the right column represents the proportion of patients postoperatively. You can see that most of the patients switched from short or ultra-short to none, although again we do see a few patients, 6.8%, who actually progressed from short to long. This is nevertheless lower than the rate of progression in the fundoplication literature, which is around 10%. The median GERD HRQL score decreased from 21 to 4 after surgery, but this decrease did not reach statistical significance. The median preoperative Demeester score was 34, which improved to a median of 13.7 postoperatively, and this was statistically significant. The overall difference in Barrett's length from pre-op to post-op was statistically significant. No patients progressed to dysplastic Barrett's during the study. Patients who had lower preoperative or postoperative Demeester scores had a higher likelihood of resolving their Barrett's. Also, for patients who had hiatal hernias preoperatively, the median difference in hiatal hernia size was 1 to 3 centimeters smaller in patients who had resolution of their Barrett's. We also conducted a subgroup analysis where we found that 71% of the patients who had followed up for 5 years or more had complete regression. A multivariate logistic regression model was created in order to identify factors which would predict resolution of the Barrett's esophagus. Here we see that the preoperative Demestre score was the only statistically significant finding, although there was a trend for BMI and gender, which have been associated with Barrett's progression or regression in the fundoplication literature. The higher the preoperative Demestre score, the less likely it was for patients to have resolution of their Barrett's post-op. In summary, placement of the magnetic sphincter augmentation device leads to long-lasting regression of Barrett's esophagus. These durable rates are much higher than those reported in the fundoplication literature. We will continue to follow these patients to determine whether their regression rates are durable up to 5 years postoperatively. Additional avenues of future research include determination of whether this reversal of intestinal metaplasia means that patients no longer require endoscopic surveillance. If so, this may be another reason to recommend magnetic sphincter augmentation over fundoplication for patients with an indication for anti-reflux surgery. Thank you very much.